Hi, everyone. I'm Dr. Stoll. I'm a neuroimmunologist at Yale University. And I see we have 15 participants, so I want to make this as interactive as possible because I find that's more fun. And let me get this light down a little bit. There. So show of hands. Well, first of all, everyone can unmute their mic. Let's see, is everyone gonna unmute? I see some people. Okay, great. Okay, perfect. Unless, of course, there's screaming kids in the background or a barking dog. And I would love to see faces. Doesn't matter if you're wearing makeup, not still in pajamas, that don't care about. Because I want this to be as close to real rounds as possible. And I also, everyone knows how to use their hands to raise hands. So show of hands, who is interested in neurology? Okay, I see one, two. Oh, a whole bunch of people. Okay, cool. So just to give you some background, and just to clarify, everyone is pre-med or thinking of medicine. Also show of hands. Yes? Okay, great. So some background on myself. I was one of those lucky ones, I guess, like all of you. I knew I wanted to be a doctor since I was 6 years old. I remember flipping through my cousin's EMT book. He was a paramedic, and those books, if anyone's ever seen them, has the craziest stuff in it, like what to do if a hand is detached from the body, or how to fix a pneumothorax, or the correct way to do CPR. And the correct way to do CPR, you're probably going to break a few ribs. So all of that stuff fascinated me as a young child, which is bizarre looking back. Now I have a 6-year-old, and some of the things that he's interested in, I see that in myself. And my older son, who's almost 10, is scared of needles and blood and everything. And when I was in high school, I volunteered at a local hospital, and one of the departments that they let me volunteer in was the ER, which in this hospital in particular was crazy. It was an inner city ER. It was a level 1 trauma center. There was blood and guts and gore everywhere, every day. And I found it just fascinating. Then I went to medical school. For the first 2 years, I was dead set on surgery. I loved it. I used to sew Barbie clothes on my Barbie dolls, and I thought, oh, I'm going to be a plastic surgeon or pediatric reconstructive surgeon because I have small hands and I can sew little things. And I'm like, this is what I want to do. And then 2 months into my 3rd year, I did 8 weeks of surgery, general surgery. And every day I wished I was in a coma just so I can sleep. I would get jealous of the patients in the ICU because they were sleeping. And then I thought, you know what, this probably isn't the best field for me, just because the hours were so grueling. It was not just physically taxing and physically demanding, but it was emotionally taxing and emotionally demanding. A lot of that has changed. There's new rules and hour regulations, so it's completely different now, but I think some of that surgeon mentality is still there. But a lot of personalities in different specialties still somewhat hold true. A lot of neurologists have certain personalities. A lot of orthopedic surgeons have certain personalities. Of course, there's blurred lines, but the field in itself tends to attract a certain type of personality. Having said that, I definitely do not fit with that personality of a neurologist. And a part of that is because, or the field of neurology is somewhat changing. I never thought I would be a neurologist. And one of the reasons for that was because I always had this preconceived notion about neurology being a field where you can make a diagnosis, but can't really do anything about it. You know, we have Alzheimer's, but we still don't have a treatment for Alzheimer's. We have Parkinson's. We don't have a cure for Parkinson's. We have brain tumors. We still don't have cures or good treatment for a lot of brain tumors that we see. Multiple sclerosis, that was when I was in medical school, the treatment options for MS was dismal. We had therapy, but they weren't that effective. Then I did a rotation at the University of Pennsylvania neurology, and I was blown away. It was like playing house every day. Do you guys know what house is? I don't know if it's still on the air. It's basically like a mystery game show of what's going on. And my specialty, being a neuroimmunologist, that's what I do. The best way to describe what I do is, has anybody read the book Brain on Fire? No? Seen the movie Brain on Fire? The movie's not as good as the book. If you're looking for a good read, if anyone has any free time, it's an excellent book. The movie, not that great, but I saw the movie and it definitely explains what's happening. And if I watched it and didn't know anything about that particular disease, I would think it's completely made up and not real and definitely not accurate. But doing what I do, it's one film that is 100% medically accurate, 100%. So I'm not going to give away that story, but I figured we can go over some cases and imaging, and then if you have any questions, again, I want this to be interactive, so ask them. And I also want you to guess. And so we're basically, the rest of the talk, we're going to go through as if we're in the hospital, we're discussing patients. Part of rounds, or this is virtual rounds, but part of real rounding in a hospital is a group of about 10 people standing outside a patient room talking about the patient. And it's literally 10 people, because you have the attending, you have the senior resident, you usually have 2 interns, and then typically 4 medical students. Then you have a nurse manager, a social worker, sometimes nutrition, sometimes pharmacy. So groups, if anyone's been in the hospital, I know during COVID, we don't do this anymore. I don't know how after COVID, these grand rounds are going to change. Or not grand rounds, these rounds are going to change, but we're going to pretend that I'm the attending, you're all my medical students, we're standing outside a patient room, and we're going to discuss the cases. Okay, so this is literally what we do in the hospital. And let me go to share my screen and play from start. Okay, so everyone can see the slideshow. Great. See here are my disclosures. Science of today is the technology of tomorrow. Case 1. Oh, here we have a 25-year-old female, no past medical history, presenting with blurred vision, painful vision in one eye, and remote history of numbness and tingling in her right. So we use a lot of acronyms. So RUE, right upper extremity. Medicine lingo is like a whole new language that you'll learn. That resolved after 2 weeks. So one of the most important things that when you present a case to an attending, so you as, let's say you're in medical school or even pre-med, when you take a history of a patient, it's age matters, gender matters, and it's the gender, or I should say the sex chromosomes matter, because with now cisgender, transgender, all of those things matter, because if somebody's on hormone therapy, you need to know. And also the gender that somebody was born with matters, because a lot of diseases are more common in one gender versus the other. And then the ethnicity of the person matters. So especially in what I do. So you want to know, is the patient Caucasian? Is the person African-American? Is the person of European descent? Is the person of African descent, Caribbean descent? These are things that matter. So I left that part out, but a full presentation for an attending will be 25-year-old, I guess, female or cisgender female, Caucasian with no significant past medical history, presenting with. So that's how every sentence starts. And then it's presenting with what? The shortest version possible. Blurred vision, chest pain, shortness of breath. So that little itty bit at the end is what they're actually coming in with, but you need that sentence to set the attending up with, because right there, just from that, you get a history. 25-year-old female is very different than 50-year-old male, because the key is what's known as a differential diagnosis. Who here has heard of a differential diagnosis? No one. Okay. So differential diagnosis is the things that it could be, right? So here I have a 25-year-old female presenting with blurred vision. So give me an example, anybody. Why would a 25-year-old present with blurred vision? Any hand raises? No? I'll go. Pink eye, conjunctivitis, got hit in the eye with a baseball, fell and damaged the eye, makeup injury, right? Lots of things, migraine. So that's,
could it be an allergic reaction or like an adverse reaction to like maybe eye drops or?
Absolutely. Absolutely. Okay. Yeah. And then I put in a remote history. So this is also, so you can say remote history, you can say 5 years ago, 10 years ago, 20 years ago, right? Because all of that makes a difference. 20 years ago, the patient was 5 years old. A 5-year-old having numbness and tingling in their arm is different than a 21-year-old having numbness and tingling in the arm. So you start to think with that remote history, what does that have to do with anything, right? What is the remote history of numbness and tingling in the arm? So give me some differentials for numbness and tingling in the arm. Let's say it was 2 years ago. Yes. Alexandria.
Sorry, I just had it in my head. Could it be like muscular, not muscular, never mind. I'm sorry. I thought I had
like a muscular skeletal issue.
Yeah.
Yeah.
I was trying to think of like the terminology.
Muscular dystrophy?
Yes, that one.
Yes, but if it was muscular dystrophy, chances are the patient would still have numbness and tingling.
Okay.
It wouldn't have gone away after 2 weeks.
Okay.
But good thought. Good thought. Anyone else? Pulled a muscle. Worked out too hard. Fell, right? Any number of things.
A pinched nerve.
Pinched nerve. Absolutely. Absolutely. And okay, so here's my differential diagnosis. So this is more for the medical student on neurology or the neuro resident. So on rounds, they always start with the lowest level of education and work their way up. And by they, I mean the attending. And the reason for that is because let's say you're pre-med and you're rotating with the team. They would ask you because we expect you to know nothing. Nothing. So if you know anything, it's fantastic. Okay? So never be embarrassed by speaking or by sounding dumb. There is no sounding dumb, especially at your level. Medical student, same thing. If it's early, depending on where you are in your medical school, if this is your first rotation, third year, and you know nothing, fantastic. We expect more if you're fourth year and this is your last rotation of medical school, okay? So then after the lowest level gives their list, their differentials, then we go to the intern. Again, intern, beginning of the year, expect you to know close to nothing. So here we have eye infection, pinched nerve, right? And you guys got that, pre-med, awesome. I would expect an intern maybe to say, maybe multiple sclerosis. I would expect a neuroresident to say optic neuritis or sarcoidosis or lymphoma. Anyone know what lymphoma is? So the two tricks, if there's anything to write down now to sound smart for anything, the two big medical maskers are lymphoma and sarcoidosis. If you say those things, it makes you sound brilliant. They can literally be anything. If somebody comes in with chest pain, shortness of breath, blurred vision, headaches, and the attending says, well, what could it be? And you say lymphoma, oh my God, wow. Then everyone's like, wow, how did you get that, you know? Or you say sarcoidosis, wow, oh my gosh. So those are the two things, the great mimickers. So if you watch House, I'm sure every other episode when Dr. House is going around saying, what could it be? Somebody will say lymphoma. The next episode, somebody will say sarcoidosis. Okay, so those are the two medical terms to remember. Who here knows what multiple sclerosis is? Scrolling down, nobody. Okay, so you're gonna learn about it. So here I'll go back up. So here we have an MRI of the brain. So MRI is magnetic resonance imaging. And as a neurologist, we get MRIs of the brain all the time. A CT is completely different. A CT is a CAT scan that takes 2 minutes, a patient's in and out. And the only thing it's good for the brain is if somebody's bleeding or not. So if anyone has a head trauma, fell off their bicycle, weren't wearing a helmet, they're taken to the ER, they have a concussion, they get a CAT scan. The CAT scan doesn't show if the person had a concussion. The CAT scan doesn't show if the person had a stroke. The only thing the CAT scan shows is if there's blood in the brain. So yes, some strokes bleed, and that would be a hemorrhagic stroke. But if it's a regular stroke or a clotting stroke, it doesn't show that. It's a common misconception that a lot of doctors don't even realize. You don't know how many times I have patients that come in and they say, yeah, I got a CAT scan and it showed that I didn't have a stroke. Well, no, the CAT scan doesn't show that you don't have a stroke, or the CAT scan doesn't show that you have a concussion. It just shows that the concussion, which is the head trauma, didn't cause any bleeding in your brain. That's it. The MRI shows everything else. MRI is what you want for a stroke, a tumor, multiple sclerosis, and anything crazy that could be in the brain. So the things that are not normal here, wait, let me see if I can get my marker out. Nope, resume share. Let's see. Remote control, no. How do because you guys can't see my mouse, can you?
We can.
Oh, you can, okay, great. Okay, so this bright white is actually fat. The black line in the middle is the skull. And then the white on the inside is the dura, which protects the brain. This black here is fluid. All of this is fluid. And then this stuff here is brain tissue. So these white spots should not be there. So this view of the brain is called axial. Axial is this. So slices going down your head this way. This is called, oh, now I can't even see my mouse. Where's my mouse? Is that weird that it's now invisible? All right. Anyway, so the other picture is sagittal view. So that's this way. And, oh, I really need my mouse. Mouse, here we go. Okay. So these white spots are the side view of these spots here. Okay. Here's your lower jaw, or one's lower jaw. Here's maxillary sinus. Here's the cerebellum. This part of the brain controls balance, and it's affected when you're drunk, which is why when you're drunk, you wobble. And then here are these spots. So just looking at this MRI and hearing the story, knowing the person is 25 years old and they're a woman and they're Caucasian, I didn't document that, but the patient's Caucasian. All of those things check box for multiple sclerosis. And then looking at this MRI, this is a classic MRI for multiple sclerosis. Okay. Multiple sclerosis is a disease that affects young, otherwise healthy, more commonly women than men, and more commonly Caucasian than African American, Asian, Hispanic, or Native American. So all of those things that I said in the differential or in that history is very suspicious for a disease like this. And what the disease does is it basically takes somebody in the prime of their life and causes these neurologic symptoms that then get better with time. So it's called relapsing remitting. Relapse, you have brand new set of symptoms. Remitting, they go away after time. And the disease eventually builds up, or these spots in the brain, they accumulate, and typically 10, 15 years after somebody has their first symptom, all of these spots build up and the patient doesn't recover as well as they used to. So it goes from relapsing remitting to progressive, where somebody just kind of goes downhill. And that's multiple sclerosis. Any questions? Okay.
I have a question. I'm sorry. I have a question. When does multiple sclerosis become like progressive? When does it stop being relapse remitting? Like at what age?
Typically 10 to 15 years after the first symptom.
Okay.
So this patient had, let's say at 20 years old, had that first symptom of numbness and tingling down that right arm. And numbness and tingling down the arm that goes away with time. That's classic for transverse myelitis. So this is transverse myelitis, or a pinched nerve. So a lot of 20-year-olds, 25-year-olds, 30-year-olds, males, females, if they have a pinched nerve, typically they'll go to their doctor, their primary care doctor, and they'll say, hey, I have this numbness or tingling, but I have full strength. It doesn't bother me. I just, I'm curious what's going on. And the doctor will ask a bunch of questions like, were you lifting something heavy? Were you playing an aggressive sport? Did you sleep on it funny? Or was there nothing that happened leading up to it? Because if there was nothing that happened leading up to it, that's concerning. If you were at the gym doing bench presses of 200 pounds and then you woke up the next morning with numbness or tingling, I wouldn't be concerned. If it happened suddenly, then that would lead me to suspect something like this, transverse myelitis. And one of the other reasons that I bring this up is because one of the clinical trials for the COVID vaccine, and again, huge proponent of COVID vaccine, everyone should get vaccinated. If you're over the age of 18, especially you guys, because young, healthy individuals, if there's no risk factors, should get vaccinated because you're the one, not you per se, but young, healthy individuals are the ones that can become asymptomatic carriers and spread it to others. So not with the mRNA vaccine, but with AstraZeneca, that company's vaccine, there were 2 cases of transverse myelitis. So transverse myelitis could be isolated, which is one and done. It happens and then it goes away and you never have to worry about anything else in the future. Or it can be part of something larger, like the first relapse of multiple sclerosis. Having said that, that transverse myelitis was found in 2 cases of the clinical trial after the vaccine. We also see this with COVID, transverse myelitis, because one of the things that can cause it, the one and done, is a virus. Not necessarily COVID, it could be a random other virus that we don't have a name for, but there's certain viruses that can attack the spine. And again, it causes a one and done. People develop symptoms, numbness or tingling, and then it goes away. By the way, I don't want to scare everybody into thinking that if you have some numbness or tingling in your hand, because we all sleep on our hands funny and we all cross our legs. I have pins and needles in my feet all the time from crossing my legs too long. Don't worry about transverse myelitis or multiple sclerosis, okay? But if you do have it and it's persistent and it lasts more than 24 hours, so symptoms that last more than 24 hours, that's when you should seek medical advice. This is the sagittal view here. So again, this way, this is the cervical spine. So the neck over here, and you can see this white spot right in the middle. So that's the white spot. This is axial view. So this way. So this is a cross section of that white spot. Differential diagnosis, just looking at this MRI, could be tumor, could be demyelinating, which is that transverse myelitis. It could be sarcoid, it could be lymphoma, right? Anything could be sarcoid or lymphoma. But after looking at a million of these, just by looking at this, I can tell you it's not a tumor or lymphoma, just the way it looks. But again, if you say that, you sound brilliant. But in cases like this, history is everything. You know, symptoms went away. That tells me it's likely not a tumor, because if it was a tumor, symptoms would persist and get worse with time. All right, case 2. Here we have an 18-year-old Albanian female, no past medical history, first presented with subjective. And the difference between subjective versus objective findings. So this is key. Subjective findings is the person is telling you what happened. Objective findings are things that you see as the medical professional with the patient. So if I say the patient notes subjective weakness, then the patient's saying they feel weak. Versus I have objective finding of the patient's weak, then I examine the patient and they were weak. That's the difference. So subjective complaint of flu-like illness. So fever, chills, cough, cold, headaches, body pain. So that's the person telling me this is what they feel, followed by extreme lethargy. Lethargy is overwhelmed tiredness. So you're all young, you probably never experienced extreme lethargy before, but I can tell you any new mother that is awake for a week straight will have extreme lethargy and generalized weakness. So their whole body, they just feel weak. Okay, so MRI. Here we're just going to go straight to the MRI. This is what the MRI looks like. So you can tell just by looking at this, all of this white stuff, not normal, right? But here you have an 18-year-old female that presents like this. Why would an 18-year-old female, no past medical history, have a brain that looks like this? Let's start with differentials. Who wants to raise their hand? I already told you 2 that you can't go wrong with, no matter what. Anybody?
Multiple sclerosis.
Okay, great. Multiple sclerosis. Anyone else? Come on, no one wants to say lymphoma? Or sarcoid? No?
I was gonna change my
I was gonna
answer
say
to sarcoidosis because of the MRI. It's a lot of white matter in her. Scan.
And all right, so sagittal view. So one of the things that you also want to look for with MRI is not just the MRI sequencing. There's like 100 different sequences for MRI. So CAT scan, patients in and out after 2 minutes. MRI can take close to an hour. So a patient's in that MRI scanner for an hour, but it's not a X-ray, or a CAT scan is like 1,000 X-rays all at once. So there's radiation. MRI, no radiation. It's a magnet. It's a magnet. So sometimes you might need to explain that to somebody that, no, you're not getting radiation. Don't worry. It's just a magnet. So here's the sagittal view, this view, and you see all of these big white fluffy spots. So part of the MRI, we can do contrast. Contrast is like a dye that we put in through the vein. And if some of these spots leak or cause a break in the blood-brain barrier, which is an extra protection around the brain to make sure infections don't get into the brain, if there's leakage or breakage of that blood-brain barrier, then you get contrast in those spots. So here, this patient has leakage out. And these are what's called rim enhancing lesions. So do you see those nice rim enhancing lesions? Do you see how it looks like a circle? And there's a dark spot in the middle. So just looking at an MRI like this, if I knew nothing about the patient and I just saw this MRI, this post-contrast MRI, I would already have a differential. And it would be MS, because multiple sclerosis causes rim enhancing lesions. It could be toxoplasmosis, which is an infection. It could be, there's a whole list of other infections, cryptococcal or cryptococcus also causes that. So that's why you don't just want to know where the patient's background, like if they're Albanian or Russian or from Jamaica. You also want to know where they're from. So, and not just where they're from, but how long they've been in America, let's say. So the 18-year-old Albanian, I would ask, how long have you been in America? 15 years. Okay, so she came over when she was. So she's coming in with acute, so brand new symptoms that just started a few days ago. She's been in this country for 15 years. So chances are this is a disease that's found in Albania, but a disease that's found in America, right? Versus if she told me that she was from Brazil and she came to the US 2 weeks ago, I would have a completely different list of a differential diagnosis, right? Because then I would pull out my computer on Google common diseases in Brazil that can cause rim enhancing lesions. And I've done this before, so I can tell you what those are. But many times, especially in different institutions, you get patients that present like this, and also different states. So East Coast, I'm in Connecticut. One of the most common things that we see in Connecticut is Lyme disease. Where are you guys? What state?
We're actually all over the world, kind of,
great.
but
Okay.
I'm currently in New York, which
Okay. Nice. Anyone else want to tell me where they're from or where they're currently at?
I'm in California.
I'm from New Jersey.
Cool.
I'm from Washington.
Nice. Washington State or Washington, D.C.?
Washington State.
Okay. So there's certain diseases in Arizona. There's certain diseases in Connecticut, Pennsylvania, New Jersey, New York, but not the city. So Lyme disease. So it matters where someone's from, and it also matters where they've been to. So if somebody recently traveled out of state and they were in Texas, you want to know. Or if, let's say I'm a physician in California and I have a patient that was just in Connecticut for a week and I see this, I want to know because Lyme disease is going to be first on my list. Okay. And let's go down. And the same thing, there's a lot of things that look like MS, but depending on the genotype, you would put something else above multiple sclerosis. So let's say this looks like MS, but instead of the patient being Albanian, they're Japanese. I would put a disease called neuromyelitis optica above MS because that's much more common in Asian descent than Caucasian descent. So it matters. And then it matters also if one parent is one and one parent is the other. So if I see somebody that looks African American, but mom is from Germany and dad is from Nigeria, that matters. Okay, so all of this matters in medicine because there's different diseases. It doesn't rule anything out. I'm still going to have, if the patient is Asian, mom is Asian, dad is Asian, I'm still going to have multiple sclerosis on my differential, but neuromyelitis optica is going to be above that. Okay, so all of this matters in medicine. So here we have our differential diagnosis. So we have multiple sclerosis, number one, because again, she's Albanian, and both parents are Albanian. And then we have acute demyelinating encephalomyelitis. So this is a term that you would think, oh my God, it's made up. It just sounds made up, right? Or, wow, this is an episode of House, because this is crazy rare. And I don't even think I learned about this in medical school, but in my field, I see this literally all the time. Adrenoleukodystrophy, something else that sounds made up. All of these things, I think there have been episodes on House. Gliomatosis cerebri. It's basically like an explosion of tumor in the brain. Sounds crazy, sounds made up, it happens. And then we have lymphoma, toxoplasmosis. So same thing for toxo that you only see in HIV or AIDS patients. So one of the things that you always want to check for is HIV. And yeah, that's your differential diagnosis. So the patient actually had, I made the diagnosis of ADEM, acute demyelinating encephalomyelitis, and then the patient turned out to then develop multiple sclerosis. So ADEM is something else that can happen with COVID, post-COVID, because it can be triggered by a virus. And COVID is one of those viruses that can trigger it. The vaccine sometimes, I don't think we've had any cases of post-vaccine ADEM, but I've seen it in other vaccines, with other vaccines, not with COVID, not with the mRNA vaccines. So Pfizer, Moderna, haven't seen it, but I have seen it with COVID. So these are things, so part of what I do is I specialize, checking for time, I specialize in the immune system and the immune health of the brain. And the brain is very tricky. So who knows what an autoimmune disease is? Who's heard of, okay, I see one. Who's heard of lupus or Crohn's disease? Rheumatoid arthritis, thyroid disease, Graves' disease, Hashimoto's. I'm seeing more and more hands go up. Let's see, scleroderma, plaque psoriasis, right? So all of these, everything I just named is an autoimmune disease where your immune system is attacking your body. With each of those diseases, your immune system is attacking, celiac disease. So for all of those diseases, your immune system is attacking one particular part. It's either attacking your gut, your colon, and Crohn's, your kidneys and lupus, your thyroid with Hashimoto's, joints with rheumatoid arthritis. So those are all diseases where your immune system goes haywire and attacks different parts of your body. There's a huge rise in autoimmune diseases nowadays, and one of the reasons behind it is because we're a much cleaner society, and especially in America. A lot of people in America, the level of autoimmune diseases have gone up tenfold in the past decade or two, and that's because we're cleaner. So our immune system is bored. You know, kids used to lick everything. They'd lick poles, they'd lick the floor, they eat off the floor, you know, the 5-second rule. It was like the who cares rule, right? Kids were just eating everything off the floor. Kids don't do that anymore. And even as adults, we wash our hands, right? And now post-COVID, I mean, we're teaching kids, like who saw the TikTok or the YouTube video or Instagram thing where there's a little 1-year-old going around touching everything. Like she sees a cup, she touches it, and then she goes like this because everything in her mind is a Purell dispenser. So she's literally like touching stuff and then going like this. I mean, as clean as kids were before, 10 years from now, because autoimmune diseases don't happen in children, they happen when the immune system is at its peak. So there's a reason kids are always sick, right? It's because their immune system is not fully developed. And old people are always sick because their immune system isn't what it used to be. But people in the prime of their life, from 20 to 40, those 20 years, that's the peak of autoimmune disease, because that's when we're the healthiest, because our immune system is the most robust. If your immune system doesn't have enough germs and diseases and bacteria and viruses that it fought off, that it has memory cells to keep it busy, then it gets bored and it starts seeing things in your own body thinking, oh, maybe that's a virus. Oh, maybe that's a bacteria. Let me attack it. And that's not saying that you should, especially during a global pandemic, you should stop washing your hands and you should eat from the floor. Definitely not recommending any of that. But just as a neuroimmunologist, I wonder if the rates of autoimmune disease are going to quadruple in 10, 20 years from now, when kids now are so clean, bathing, washing their hands all the time. I just wonder what's going to happen. Anyway, because it's the butterfly effect, right? There's always long-term downstream effects from everything. Having said that, multiple sclerosis is an autoimmune disease, but instead of your immune system attacking your bones, your joints, your skin, it attacks your brain and your spinal cord. That's all it is. Not that that's all it is, but that's what it is. It's your immune system. So sometimes when you get a virus like COVID or something else random, your body looks at it and tries to attack it, but sometimes different things in your body look similar to that virus, and it gets confused and it attacks you instead. So that's how we end up with these other rare diseases in random conditions, like post-COVID ADEM, this acute demyelinating encephalomyelitis, or something like that. So that's my specialty, basically trying to figure out what's going on with the immune system when it comes to the brain and the spinal cord. Cool stuff, right? If you weren't the patient, of course. So here we have another MRI. Here you have 2 spots. Do you see those little 2 spots? Here's another spot. Here's another spot. So this is where you get, now you guys are experts at reading MRIs, so I'm sure you can see those spots. So it looks somewhat normal except for these spots. So differential diagnosis, we have our MS, sarcoid, lymphoma, right? Depends how old the patient is. If this person is 70, I would say, wow, that's a phenomenal looking brain for a 70-year-old. Only 2 spots, lucky you. Because a certain amount of spots are normal for age. If this is an 18-year-old, I would say, wow, That's not normal. An 18-year-old brain should not have white spots that look like this. This is actually a 55-year-old male, Caucasian male. Here's the rest of the brain. This is lower down, so axial. So this is right here, right by the nose. And you can see that it's right by the nose. You can see this is the nose. So if somebody has a deviated septum, this is the septum. So this guy has a pretty straight septum. Here are the eyes. Here's that cerebellum back here. And then this is called the pons or the midbrain. So do you see this white stuff here in the pons? And then on this slide, it's all this. So now what's on the differential? Same thing, right? MS, sarcoid, lymphoma. Here we have post-contrast MRI. So this is what's called a coronal section. So this is this way. So now we did all three planes. So axial is this, sagittal is this, coronal is this. So look at that. Is that rim enhancing? No. The whole thing's enhancing, right? Looks like a tumor. But if I told you the patient is a 55-year-old Caucasian male with double vision, that double vision comes and goes. So if it comes and goes, so let's say it lasted 2 weeks and then it went away. It kind of gets rid of that tumor idea because again, tumors grow. They don't cause symptoms and then the symptoms go away all of a sudden. So history. You have to get a good history. So actually that patient had sarcoid. Whoops. This is sarcoid, the big mimicker. But it looks bad. Looks like really bad sarcoid. But just the fact that the symptoms come and go rules out or puts lower on the list tumor. Here we have another brain. So you can see all of this white stuff, right? So differential diagnosis includes what? Let's see some hands. Anybody? I see a hand, but the mic is muted. No one? Everyone's being shy? All right. MS, right? Could be MS because of all this white stuff.
I have a question.
Sure.
So if the MRI looks like a possible or a differential diagnosis of MS, how can you tell if like the advancing like stage of MS is in? If it like is it the like mass of white in the MRI? Does that matter?
Yeah. No, great question. So I look at this MRI and I think, wow, that looks terrible. Okay, these ventricles are huge. So let's look at that last guy. So this, do you see these ventricles? It's called slit-like because they look like little slits. This is minus these spots. This is how all of your brain should look. This is a healthy, I would think 20-year-old brain. Ventricles are tiny, and that means there's not a lot of atrophy, so brain shrinkage. So if this was a 55-year-old guy. So I was like, wow, that's a healthy looking brain for a 55-year-old guy. Now, if I told you this is so with African American, there's a lower risk of MS, but when it happens, it's much more severe. So again, that's something you need to know because as a neuroimmunologist, I'm going to be more aggressive with treatment upfront than I would for a Caucasian patient or male versus female. So that's something else you need to know. Transgender versus cisgender, all of those things matter. If I'm looking at somebody and they look female, but chromosome-wise, they're XY, they're male, and they have MS, I'm going to treat them differently upfront because they have a worse prognosis. So they have a much higher rate of being in a wheelchair than a Caucasian female. So all of those things matter. So this is actually a Hispanic woman. So Hispanic also, we know less about the Hispanic population because MS wasn't, it's very driven. Where on the equator or where on the axis of the world you're from. So the chances of developing MS it doesn't matter how old the patient is now, it's where, or the prevalence of developing MS, it's where you spent the first 15 years of your life. So again, if I have a patient that spent the first 15 years of their life in Ecuador, but now they're in Connecticut, it matters versus if they spent their first 15 years of their life in Connecticut or Toronto, where there's almost no vitamin D because no one's outside, right? And then they move to Ecuador, it's very different. So it's how vitamin D deficient they are or they were. So the Hispanic population being closer to the equator, there was less prevalence of MS. But now with migration and where people end up and where people live for the first 15 years, that's what matters. So there isn't that much data or research on Hispanic population. I know there's a big chunk of MS in Cuba and it's crazy. I don't know, and with the migration, because we're doing genetic studies of where those patients are originally from, like if they immigrated from Europe, but they've spent the past 200 years in Cuba, but genetically they're European, so European ancestor, but they've lived in Cuba for 200 years. That's my guess, because again, the Eastern European genetics, that's the common MS or autoimmune link or variable. So if I ask a patient, okay, look African American, but I want to know genetically, mom, dad, where your parents from or where your grandparents from, because it makes a difference, not only in the diagnosis, but also in the risk of disability. So being wheelchair bound. Having said that, so this patient is a 40-year-old Hispanic woman. I think she's originally from Mexico, with longstanding multiple sclerosis. However, she then developed acute worsening of her disease. So all of this white stuff was from longstanding MS, but guess what her disability was? 0. No disability whatsoever. So the MRI doesn't matter, and you cannot tell from an MRI if somebody has progressive disease or relapsing remitting or what level of disability they're at. So that's something, the picture helps with the diagnosis, but it cannot tell you how disabled somebody is or where they're going to end up on their disability curve. So having known this patient for the past 6 years, she's on a great treatment. I suspect that she is not going to be disabled or have any further deterioration from her MS, from just age or high blood pressure, diabetes. If she were to develop any of those things, that's another story. But from her MS, no. So the thing with her is, though, a few years ago, she started going downhill really, really quickly, started having seizures all the time. Daughter brought her into the hospital. She wasn't making any sense. She was basically lethargic, so wasn't waking up. And we were trying to figure out what's going on. So she had MS, that we knew, but what else was going on? So we got an MRI, and her MRI showed this. So do you see these black holes here and this black hole here? So that black hole tells me that there's no brain tissue. It's the absence of brain tissue. So it's not a tumor. There's nothing there. There's literally nothing there. It's like somebody went in and cut out a kidney-shaped hole in her brain. So you can see the other side, what it's supposed to look like. Anyone know what this part is of the brain? So it's called the hippocampus. So the hippocampus is memory, what forms new memories. And there's one disease that loves eating the hippocampus. Anyone know what that is? Herpes. Herpes encephalitis causes seizure after seizure after seizure. And if you don't treat the herpes, then eventually the disease eats away at your brain. So this patient was suspected to have something else that can happen with certain medications with MS called PML. PML is a brain-eating infection, and it's treated one way. It's basically treated by stopping the medication that the patient's on. It can also happen with HIV, AIDS, and it can also happen with chemotherapy, this brain-eating infection. Nobody thought that this patient had herpes encephalitis. And that's what happens when you narrow down somebody's differential based on what they look like, their education, their history, their family history. That's what happens. So in medicine, one of the things that you always have to remember is your differential should be as big as possible. So that list of possibilities, it should never just have one or two things on it. So as an attending, the worst thing you can do for your patient is put them in a box and give them a few differentials based on everything I told you to judge somebody based on, right? So their ethnicity, their background, their sex, their gender, that's where you start. That's your number one, number two, number three, right? But you have to open it up and you have to keep it open until you rule out every possibility. Because had herpes encephalitis been on her differential, we could have saved that brain tissue because there's a treatment, acyclovir. Could have given her acyclovir early on, stopped the seizures, gotten rid of the herpes. But everyone thought it was something else. Everyone thought, oh, it's gotta be PML because she has MS, she's on Tysabri. We all know Tysabri causes PML, it's PML. So you never narrow down and you never put somebody in a box. This woman was married, happily married for 20 years, devoted husband, loving mother, right? No STD history. We always check HIV in anybody that comes in just because it's standard of care now, you check HIV. But syphilis can cause holes in the brain. Herpes can cause holes in the brain. These are things that you always want to keep on the differential because you're only hurting the patient if you don't. Having said that, so herpes eats away your hippocampus, which is your memory. This patient, you look at her, she looks incredible, she looks fantastic, has no short-term memory, cannot remember anything that happens within like a 1-day period. So she'll do something and then she'll ask you 5 minutes later the exact same question. Okay, but walking, talking, looks great, can drive. She has now, this has been going on for 6 years. She keeps a journal with her that's this big because she's gotten used to dealing with her loss of short-term memory so much, is compensated so well. She basically writes everything down. Before she even asks a question, she knows what page to turn to in her journal to see if it was just answered. So she's literally writing down my answer and then ready to ask the question again and looks to see what the answer is. So this is another patient. So this is long-standing MS. This looks like an 80-year-old brain, but it's actually a 40-year-old patient again. But looking at this MRI, I could not tell you anything. I couldn't say if this is MS, if this is normal aging, anything without a history. So again, I need a history, right? So this is where radiologists suffer. If anybody wants to go into radiology, you'll look at MRIs like this. You'll have a differential. Your differential will have 100 things on it. And if the patient sees the radiology report before seeing the doctor, they'll think they're dying. And this is one of the problems with medicine these days, with healthcare in general. There's a new rule that patients have to get all of their test results, their imaging results, their blood work results immediately. The second it's finalized, so the second the radiologist finalizes this MRI, it's released to the patient. So a differential for a radiologist could be, you know, lymphoma, gliomatosis cerebri, which is like the, you know, exploding tumor in the brain. It could be ADEM, it could be MS, it could be anything. And then the patient sits there and Googles, right? And then they call obsessively to the doctor. The radiologist says, I have a tumor. The radiologist says, I have MS. The radiologist says, I have strokes. What's going on? I'm freaking out, right? So this is where sometimes healthcare or the government does not match up with what should be happening, because this could just be normal. If the patient was 80 or 85, 90 years old, this is a normal 80-year-old brain. But that's where you have to have medicine of today, right? Everyone's Googling everything. People don't rely on medical expert opinion anymore. Everyone's their own doctor. Everyone's getting their medical information from Sharon on Facebook, which is awesome for the physician, because the patient comes in with what they think they have. So a lot of times now patients come in with their differential, which is always fun for me. Most important thing to remember is you always, always, always take a good history, because the history is more important than the MRI. And that's it. Questions? I think I went a little over. I apologize for that. Anybody? Yes, Alexandria?
Will there ever be, because I know how you said that patients come in with their own differential diagnosis, will there ever be a chance where they're like correct in the terms of their diagnosis?
Yeah, absolutely.
Okay.
I have that come in and say, I think I have multiple sclerosis, I'm worried about MS. And right, they have MS, but it's not, I don't stop there. Somebody comes in with their list of what it could be. I still have to work them up for everything else that it could be, because otherwise that would make me a terrible doctor.
Mm-hmm. I mean,
that's WebMD, basically. Somebody Googles their symptoms and then they freak out. You know, I mean, could you imagine if everyone with numbness and tingling Google their symptoms and on that list it has transverse myelitis or MS? Right?
Yeah.
So this is where the doctors come in, because again, a good primary care doctor will say, okay, well, did you do any strenuous activity yesterday? Oh yeah, I did. And I actually felt a pop because I was doing this, you know, Ironman thing, and I felt a pop in my arm. And oh yeah, no, I guess that makes sense, numbness and tingling. Okay, cool. I thought I had MS, you know? So that's where an actual physician helps. But yeah, I've had people come in, we're worried about one thing and they were right.
I have a quick question.
Sure.
What does a typical schedule look like for you?
So for me, I see patients 2 days a week. 8 to 5, 6 sometimes. And then I have a day where I do admin time, because nowadays, if you can't see patients in the clinic 4 days a week or 5 days a week, because you don't have enough time to call all those patients back for all of those results. And there's a lot of doctor to doctor talks. You know, I get referrals from other physicians, or I have to speak to another physician about one of my patients. So there's a lot of what's called administrative time, but it's really just time to make all those phone calls. And then I do research the rest of the time. So I work on clinical trials, and I also do a lot of education. So I'm the program director for our annual CME course. So CME stands for Continuing Medical Education. So all physicians have to stay up to date on their specialty, which is really important, especially nowadays, because every other minute there's new criteria for different diseases. And you want to make sure you stay up to date on all of that. Any other question? And then of course there's the call. So after hours, being on call. But as a neurologist, or as a neuroimmunologist, I just take call for my group's patients. So general neuro, or the attending on staff in the hospital, is the one that would need to go into the hospital to take care of those patients if something urgent happens overnight. But for my specialty, there's nothing urgent that happens between 6 p.m. and 7 a.m. If I was a stroke neurologist, that would be a different story. Any other questions?
I had a question.
Sure.
So, what makes it difficult, like when you're working with the brain specifically? Because I don't know, I hear a lot of theories that the brain is so different when you're working with other organs. So there's like a lot of things you need to like be careful with. Because if you're diagnosing like a patient, you have to be careful. Is it really that diagnosis that matches with the patient's history or not? If that makes sense.
So one of the things that make it the most difficult is you can't biopsy it. I could biopsy the liver, the lung, the kidney, the skin, everything. But you could also biopsy the brain, but you don't really want to. So sometimes, though, you need a tissue diagnosis. But with a tissue diagnosis of the brain, you also want to get the smallest tissue possible, because everything in the brain accounts for something. So if you suspect a tumor, you need a biopsy to confirm if that's a tumor, and also what type of tumor it is. There's another diagnosis that I didn't talk about that you can only make on biopsy, but almost no one gets a biopsy, and that's vasculitis. So vasculitis is something else that can look like anything in the brain. And you can only make a affirmative diagnosis with tissue, but you don't really want to go in and get that tissue. So that's why it's so difficult. The good news is there's a lot of overlap in treatment. So if I'm not sure if somebody has ADEM or MS or neuromyelitis optica, guess what? The acute treatment, so the treatment in the hospital, is the same for all three. It doesn't matter what the diagnosis is. The treatment is still the same. And then you can figure it out later on, depending on what happens. And that's where more history comes in. What happens over time? Does it get better over time? Does it relapse over time? Does it progress over time? So it's like playing Monday morning quarterback, where sometimes I'm like the fourth neurologist that sees the patient. Being the fourth, I'm in a great place because more time has passed since that patient was initially seen. So I always look like the hero, because 6 months went by, and in that 6-month period, I could find out more of what happened to that patient than that first neurologist. And that first neurologist might have said it's ADEM, but me being the fourth neurologist, Now I'm saying, no, it's MS, or no, it's NMO. So I have that advantage because time is, it just provides more data. But it's very difficult. But you played detective. Any other questions? These are all great questions, by the way.
I have another quick question, sorry. Do you ever perform any procedures?
Yes. So spinal taps, lumbar punctures. I also do baclofen pumps. Baclofen, it's called intrathecal baclofen trials. Or I refill baclofen pumps, which is basically like this device that sits in somebody's stomach like this. So small procedures, but a lot of things are done with the smallest knife or the smallest needle, minimally invasive, as they say. But yeah, I also do a lot of Botox for muscle tightness. Trigger point injections, those are fun. Anything else?
I also had a quick question. So where do you get your statistics, like, knowing about Hispanics, Caucasians, and like knowing various different ethnicities? Because I noticed that you always take that as a consideration. I'm just curious.
Yeah. So the National Multiple Sclerosis Society did a large trial many years ago. And unfortunately, we're still using a lot of data from that original trial. So the data from that, it basically showed that no Native Americans develop multiple sclerosis. Is that accurate now? Probably not, but that's what it says. And then again, 2/3, and then there's also lots of other publications after that, but that original trial was a large trial with a lot of data, but it was just US data. And US data is also very fragmented because we don't have socialized medicine. So you only see what certain insurance companies or certain societies collect. All of those surveys that people fill out, I know I've never filled one out. And I'm sure a lot of other people don't fill it out. And so that's why we're probably missing a lot of data, because we just don't have it. So then you look at national MS societies in other countries. And I can tell you 20 years ago, there was almost no data on the Middle East, on multiple sclerosis in the Middle East, because MS, first of all, it didn't really affect too many people in the Middle East. And now we're seeing so much multiple sclerosis in the Middle East. And I can tell you, just being in America on the East Coast, we have so many patients that come from Saudi Arabia, Iran, Iraq to get treated for MS. Every year, we also have a fellow from Saudi Arabia sponsored by the Saudi Arabian government. And that's been somewhat new. That started happening 4 years ago. And they tell us what's going on in their country, that they need more MS doctors, which is why the government is funding them to get educated in the US and then go back to Saudi Arabia to be an MS specialist. And so one of the reasons I mentioned Brazil, now there's a National MS Society in Brazil, or I shouldn't say National MS Society. It's called, so the American Conference for Treatment and Research in MS is called ACTRMS. So the American Treatment Research in Multiple Sclerosis, that's what it stands for. Everyone goes to what's called ECTRMS, which is the European Conference for Treatment and Research in MS. That's our big conference. The American Society, ACTRMS, isn't as big or as popular as the European one is. So that's the one everyone goes to. And from there, they actually had a presentation of all of the different now societies or groups or conferences that have popped up all over the world. So Brazil has one, the Middle East has one, Russia has one, and how many members each of these societies have. So from there, you can kind of detect how many patients are in those countries that have certain diseases. Yeah. But a lot of my data comes from this original trial that was done by the National MS Society. And that's where I quote the numbers from, but that's definitely not currently accurate because it was done a long time ago. And that's where a lot of papers or publications coin or say that the prevalence of MS in the United States is 450,000. So that was just updated, I think a year or two ago, to 973,000 in the US, but it wasn't redone for the world. So for the world, we still have 2.3 million worldwide, but I'm pretty sure that number is also from the 1970s. So it's definitely not accurate data, but that's unfortunately the most up-to-date that we have. We have a lot of other smaller publications that will say, no, the prevalence of female to male in multiple sclerosis is more 50-50. But if one of the things they have to look for in a clinical trial or a epidemiologic study is how it was done and what the sample size was, and also the population. So California they can do good data because they have somewhat of a closed system. But again, that's California. So California has a larger number of Hispanics than Connecticut or Pennsylvania. So the studies that I look at when quoting numbers are US studies, not state studies. I hope that helps.
I just wanted to say thank you for coming.
That was a long answer to probably what you thought was going to be a short, Sharon.
Yeah, so thank you again for coming. Your presentation was really amazing. And just talking about some cases and sharing personal details was really great. So thank you again.
Sure, thanks. Thanks for having me.
So any last questions? Okay. Okay, so thank you again so much for coming. And
sure.
That's it. Okay.
Okay, great.
Thank
you for having me.
Thank you.